So good afternoon, everybody. It's very strange doing a presentation when I can't see people in person, but we'll go with it. So as Ruth said, my name's Kathryn Dooley and I'm a speech and language therapist. I work for Wrightington, Wigan and Leigh NHS Trust. I'm based over at Leigh Infirmary and I'm part of the Neuro community team. So I often go out and see a variety of patients with neurological disorders and obviously in particular Huntington's disease, which is what this presentation is obviously about this afternoon. I'm not an expert in Huntington's by any stretch, so I won't have all the answers, but I'm hoping to give you a bit of a basic overview of some of the problems that these people face. Okay, so the purpose of today's session, I'm hoping, is to just have a little quick run through the symptoms of Huntington's and how they impact on communication and swallowing, the importance of communication and swallow, the types of communication and swallowing difficulties people with Huntington's face, recognising those problems and the strategies that you can use to help, and what is our role, what's the role of the speech and language therapist in helping these people. Okay, so some of the symptoms, you see a lot of physical symptoms in this disease. So some of the early complaints that you find, a bit of clumsiness, they're often off balance, they have some minor involuntary movements and eye movements. Then this leads on to a severe chorea. So these are like myoclonic jerks, which are basically twitches, which are due to sudden contractions in the muscle. These tend to become a bit more frequent and progressive, and it's those movements that can't be controlled. Sometimes as well, they become quite rigid in the movement, and sometimes it can lead to people becoming bedbound. It's important to remember that Huntington's can bring on more than just the physical changes. It also includes the cognitive and behavioural changes. So you see difficulties with perception, judgment, some awareness changes, lack of concentration. They can develop dementia-like symptoms. They can also become quite obsessive or manic, sort of schizophrenia type symptoms. Sometimes they lose their inhibition, so that can cause sometimes lack of personal hygiene and self-care. Sometimes they're very much in denial about the difficulties, which makes treating them and helping them quite difficult. Obviously some intellectual and mood problems. Sometimes they can be depressed and irritable. And all these things will have a big impact on the person's ability to communicate, which we'll now go on to talk about first. So let's talk about the communication process. It's something we all take for granted, and it's something we do very quickly without much thought. But if we break it down, you can see it's a lot more complicated process. So today I'm just focusing mainly on the verbal communication, but obviously there are other ways of communicating using the written word, pictures, symbols, drawings, gestures, all those kinds of things. Okay, so first of all, when someone starts to say something to you, the first thing you obviously need to do is hear them, hear what they're saying to you. Then you obviously need to understand what their message is, what they've asked you, and then you need to formulate your own message. So you need to think how you're going to respond to that message. You need to be able to find the right words, put these words into a sentence, and then obviously you need to be able to speak your message. Say what you need to say. So coordinate the muscles of your mouth using the correct pitch, the correct volume, the correct tone. And breakdown can happen at any of those stages for people with Huntington's. So just for now, it's a bit tricky to do this online, but I just want you to take a few seconds and imagine that you can't speak your message. You're struggling to communicate, you can't write anymore, you can't draw anymore. And just take a little second to think about how that would make you feel. How would it feel for you not be able to get your message across to your loved ones, your friends, your family? I'll give you only a few seconds. So I'm assuming for most of you, some of these things will have come up. You may feel quite frustrated or angry that no one understands you, despite the fact that you're trying your best to communicate. You might want to give up. You might feel that there's no point in trying anymore. It might make you feel silly or stupid, and then that person might want to shy away from talking, and obviously that would make you feel quite fed up. And you sometimes might be quite confused, as it may sound normal to you in your head, You know exactly what you want to say to people, but it's just not able to come out, and you're confused as to why others don't understand you because it sounds perfectly normal to you. So not a nice feeling for those people. So why is it important to understand communication? So communication is central to all we are and all we do. It's a basic human right, and it's how we let others know about our needs, wishes, ideas, concerns and opinions. And it's how we develop and maintain our friendships and relationships. And it's how we control what happens in our lives. It's the way we tell people we don't like something or we're happy to do something. So imagine how scary and isolating it must feel to have people not understand you or you not understand them. Okay, so as we've just discussed, how important communication is to us all, the difficulties that people with Huntington's face with communication can lead to a sense of loss or trauma. You know, they've lost the speech, bewilderment and confusion, like we said before. They might be fearful, they're in shock that something they've had all their life suddenly disappears, can cause depression and frustration. Also can have quite a negative impact on relationships, you know, if they're suddenly unable to communicate with the partner and just have those nice conversations that you normally would do. So it becomes a bit of a day-to-day struggle with that interaction and conversation. And you need to make long-term and quite profound adjustments when you're struggling to communicate. You know, the way that you communicate needs to change, and therefore your relationships will change also. Okay. So just going to move on to some of the problems that people with Huntington's face. So they're often unable to control the muscles for speech as well as they could before, and this is what we call dysarthria. And it just describes basically a difficulty with articulation, so it becomes quite unclear. We often describe it as slurred speech, so it's quite slurred or very weak articulation. They often also have quite a weak voice. Sometimes it can sound a bit strained, a little bit hoarse. They may have difficulties with controlling the volume, so it might be quite quiet. They also have difficulty with the breath support, which is very important for speech. So they have difficulty coordinating the two things, so breathing and speaking at the same time. So sometimes it might sound like they're shouting quite angrily, but actually it's a result of trying to control the volume and control the breathing all at the same time. You might see what we call hypernasality. So you get too much air escaping from the nose in speech, so it makes it sound strange. Their voice might change, so it might become quite monotonous, so you're not getting that rise and fall in pitch. And sometimes it can also sound quite robotic or choppy when they're speaking. So you get some like inappropriate pauses between words. So sometimes it just sounds a bit strange. And sometimes they can speed up to sound very, very fast, or sometimes the speech can slow down. And those are the kind of things you tend to notice with dysarthria. So thinking back to the communication process we discussed before, the changes in the brain in someone with Huntington's means that they struggle to articulate what they want to say. They find it hard to start a conversation. They may have difficulties in understanding what you're saying to them, and that can be from the spoken word, or it can even be through written language as well. Then they have difficulties in that formulation of language, so putting those words together to form sentences. And again, that can happen in the spoken word or when they're writing too. So sometimes they get stuck on topics, they can't move on. They may repeat words that are important to them. And as we just discussed with the dysarthria, the motor planning stage of speech or the non-speech movements can affect how their communication is. It also affects their social skills. So you often see strange interactions with the non-verbal skills. So they might have difficulty with eye contact, with turn taking, keeping attention, monitoring themselves, and obviously anxiety and depression is quite common. And changes to your daily routines can increase anxiety, and they are just focused on this one thing. So, and obviously communication will suffer if somebody's got anxiety or is depressed. They've got no drive to organise their thoughts into words. They have difficulty in group situations, so they withdraw sometimes and become quite isolated. And it becomes a bit of a vicious cycle of sort of decreasing communication and impacting on each other. So, what can we offer as speech and language therapists to help with these types of clients? So we often offer strategies and advice and ways to make communication that little bit more easy for both parties. Sometimes we'll look at alternative means of communication. So by that we mean things like picture charts or alphabet charts, or sometimes we will consider high-tech devices. So I'll just go on and talk about that a little bit more now. Okay, so there's quite a lot on this slide. I'll try and talk you through it. So strategies to support communication are really, really good tools and a good place to start. Just being aware of being face-to-face with someone so that you're paying attention to the person speaking. You can watch them speaking, and that might help your understanding of what they're trying to say. Using good eye contact, being at eye level with a person helps too. Sometimes we'll use cueing techniques. So things like if you were struggling to find a word, for example, you can give them what we call the sentence completion. So say if the target word was something like bed, you could say, and they were struggling to get that, you'd say, you sleep in a, and that might cue them in to getting that word. Also describing the word. So again, this is for both parties. If someone is struggling to say something and they can't find the right word, you can ask them to try and describe that word and see if that helps. Or if you again know roughly the word that they're going for, you can describe the word to them. So if they were going for coat, for example, you could just say, oh, it's something you wear, you put it on when you go outside, and see if that helps them find the word. And another thing we try as well is giving the person the first aid. So again, say the target word was something like television, you would say, that's right, it's a telly, and hopefully they would be able to finish that sentence. And then you again, the person with Huntington can sometimes use those strategies as well. So you can ask them, can you do the first sound? Can you describe the word? And again, encouraging gesture. So you using gesture, pointing, miming, those kind of things can also help from an understanding point of view and helping the person with Huntington communicate with you. Environment is very important. Try and keep it as quiet as you can, avoiding distractions, because people with Huntington's find it difficult to do two things at once. So walking and talking is difficult, or trying to chat when the TV is on, and making sure that you talk one at a time in a calm, relaxed way. Try and speak as slow and simply as you can, obviously not too patronising, but using familiar words. So using the words things like friends and neighbours rather than residents, or hobbies rather than recreation activities, so sort of more simple terminology. And make sure you're using the same words each time, don't chop and change the words that you kind of use. We also suggest you use things like active sentences rather than sort of passive ones. So, for example, rather than saying at 5 o'clock we'll have our tea, you're definitely doing an active sentence, which would be something like tea is at 5 o'clock. Keywords again are quite appropriate. Sometimes when you're talking to someone and you give too much language, they're missing the meaning. You know, if you're saying to somebody, would you like a lovely cup of tea now? That's quite a lot of words to sort of take on board and respond to. So just something as simple as tea, maybe gesture and a cup of tea would be easier for someone to understand if they're struggling. And again, keeping pitch, you know, your speech slow, steady, a lower pitch and a conversational tone tend to be much easier for somebody to hear. It's important to remember as well that the Huntington's patients often process information and form response. It takes a bit longer for them to do that. So they might feel like there's a bit of a timeline of you asking something and then responding. Try not to jump in and repeat the question, as that will interrupt that process of them thinking. So it's often better to just give a little bit of time and wait. Listening to the real message, so looking out for the emotional tone rather than what it is they're saying, so how they're feeling rather than the words. Accepting all forms of communication, so gesture, pointing, drawing, anything that they're using. Try and avoid talking for the person. That can be quite difficult when you feel like you're just trying to help, and some people will want you to do that, and it's important to set those ground rules. Do you want me to help you? Do you want me to wait? And you try and get the sentence. Trying to avoid abstract or vague topics, making every opportunity that you can to engage in conversation. Obviously, never talk about the person as if they're not there. You know, when your professionals come, you know, try and let them answer, and obviously ask if you know, they want you to talk for them. And yeah, say if you don't understand them. An easy way, if you've not understood understood the whole sentence, but you've got bits of it, is to repeat the part back that you have understood. And then that saves them having to try and do the whole sentence again. Asking more of a yes/no question, so rather than an open question, and that can sometimes help you clarify what it is they're trying to get, and limiting that choice to help with the decision making. So those closed questions. Sometimes you find that people with Huntington's often say no as an initial response, but again, just giving them time to, as they might change their mind and then they might actually agree. The importance of consistent routine, so thinking about communication, leaving it to good times of the day when they're less fatigued, less tired, and staying on topic, so gentle prompting to stay on topic and not sort of wandering off topic. And it's easier if you're having a conversation if it is centered around one topic, not many different topics, and not moving on to another topic too quickly is helpful. And just at the end, really, there, acknowledging any confusion that they have, any upset, any anger, frustration. Try not to be surprised or upset or embarrassed by the person's communication difficulties, especially swearing. Sometimes that happens. And if you find that a conversation is going round in circles, just have a break and then try and continue it again later. And the main thing really is listening. It takes effort for someone with Huntington's to be able to speak, so you need to listen carefully and give that person that time. So, like we said earlier, there are other alternatives that we can offer for people. So we can make a picture chart for somebody. It's just an example here. What we tend to do if we do something like that is we make it personalised to the individual, and sometimes we can use real photos. The issue with this is, in order to use this, you need to have what we call symbolic understanding. So you need to understand, for example, that this man here that is shivering is actually cold, and you have to choose that to show that you were cold. Also, you can only have a limited number of pictures physically on a chart, and it does tend to only help you with these sort of basic needs, as you can see from the picture on the screen there. So it's not great for conversation starters and that kind of thing. And again, because you can only have a limited amount on a page, you're going to have to then have lots and lots of different pages, and that can be quite confusing for somebody to use and flick through. An alternative idea, if you feel like something like this is too much, is to create something like a board, a whiteboard, for example, and you can centralise your routines on that, your appointments, keep writing nice and simple, so it's just something to go to a visual reminder. You can use one picture sometimes, flashcards of objects they know, so use familiar pictures of the objects themselves. So you can take pictures on your phone device, and these are good for meal planning, so enabling them to choose menu options, for example. And the important thing to say about any kind of communication aid really is it's most effective when it's used early on and it's used regularly. It's no good being put in a drawer and then only coming out when the speech therapist comes to visit, which can happen sometimes. And then moving on to the next thing that we might offer is alphabet charts and sometimes high-tech devices. Both of these tend to be quite difficult to use because of some of the cognitive challenges that people with Huntington's face, and they can be quite time-consuming, and that will depend on the method that people are using to access it. Obviously, to use an alphabet chart or a high-tech device, it requires intact written language skills and spelling skills, obviously, or nearly intact. And it can be quite slow and cumbersome to use. And you need to think about how they're going to access that. So if people don't have the motor skills, which obviously in the Huntington's is affected, if they can't point to the picture, or they can't type, for example, or they can't point to the letter, you can do other things. You can access things like this via a switch, which you tap along with, or with an alphabet chart. A partner, relative, carer can help along. So they would start at line 1 and say, is it on this line? Is it on this line? Is it on this line? Waiting for a yes, no response or whatever response, and then going along each letter till you get to the right letter. And that's kind of how the high-tech devices work. It will scan across each line, and you hit a switch in whichever way you can, and then go along each line to get the letter. So as you can imagine, that's quite tiring, quite laborious, and obviously it's difficult for those with cognitive difficulties to use as well. If you think about even Stephen Hawking took days and months even to write some of the speeches that you saw him do on the television. and that involves a team of people to help him. So it's not always as easy as it looks, but it definitely can be useful. Okay, so that's the communication section over with. So I'm now going to move on to the swallow. Okay, so the purpose of the swallow. So why do we have a swallow? What do we use it for? So it's to obviously process and transport our food and drink from our mouth down to our stomach, and it's there to protect our airway and lungs from food and liquid going down into the lungs, and obviously that's going to cause you injury, irritation, and or infection. So it's a very important thing. Okay, so what do we need for successful eating and drinking? So you've got to recognise at first that you're hungry and you're thirsty. You've then got to be able to find and recognise something that's edible to eat. You've then got to be able to transfer that food from your mouth. You've got to judge how much to put in the mouth at one time, judge how quickly or slowly to eat or drink. You've got to concentrate throughout and continue with the meal. You've got to be able to taste, recognise a variety of foods and flavours. You've got to chew effectively. Then you've got to get the food to the back of the mouth, and then you've got to coordinate all the muscles in order to swallow and direct the food into the esophagus or your food pipe, and whilst protecting the airway. And all of the above things need to be successful to maintain your nutrition and hydration. Okay, so I'm going to talk a little bit about the normal swallow before we move on to discovering the difficulties. So I'm hoping that you can see my cursor here on the screen. So I'll just orientate you to some of the points on the diagram there. So obviously here we've got the nose going down into the lips. We've got the teeth here. Over the top here, this is your soft palate, the roof of your mouth. This black bit in the middle here is our food or our liquid. And then this big muscle here, that's our tongue coming down into the throat. We have this big sticky out thing here, that's your epiglottis, that's the big flap that comes over and protects your airway. So here, this big gap here is your airway. And then here down the side here is your esophagus, your food pipe, where we hope that the food and drink is going to go. Okay, so when the swallow starts, it starts right at the beginning, at the sight of food and the smell, and that stimulates the swallowing process. So we take a bite or a sip, and we close our lips. So here, this person here has got the lips closed. We chew the food, or we hold the liquid with the front of our tongue, and we form the food into what we call a bolus, a blob, on our tongue. So our tongue here comes up at the front and moves the food or the liquid back towards the throat, and that's done in like a scraping motion. And the time taken for this oral stage depends mainly on the food or the drink that you're having and its consistency. So that will depend on what you're actually having. Okay. The next stage of the swallow is what we call the pharyngeal stage, so when it gets into your throat. So once the food tips over the back of the tongue, so you can see that the bolus here has gone right over the back of the tongue. The following happens, and this is the point of no return. You can't control it once it gets to this point, it becomes an automatic thing. And this phase normally only takes about less than a second to complete, so it's very, very quick. So what happens is the food is moved back, your soft palate here comes down and it closes off your nasal cavity so you don't forget things coming back and going through your nose. Your throat, your voice box lifts up and rises, pulls forward, and then what that does is it pulls the epiglottis down and it comes over and it covers the airway there. Another layer of protection is down here, which is not quite on the screen. You have your vocal cords and they close and you stop breathing. And then your esophagus, your food tube opens up here, and then the food and the drink drops down into the esophagus. And all that happens in less than a second. So it's quite a complicated process, as you can see. And then the last part is what we call the esophageal phase. So food and fluid passes down, as you can see, down into the esophagus, and it goes down to the stomach by something called peristalsis, which is like a muscular wave. It kind of goes like this and squeezes your food and your drink down, and that takes about 8 to 10 seconds roughly, and that's the part that tends to be mostly affected by aging. And a point to say about this phase is that speech and language therapists are not involved in assessing or managing this stage of the swallow. It's something that we might then pass on and refer on to someone like gastroenterology. Okay. So how does Huntington's impact on eating and drinking? Okay, so as we've said before, they have these career-like movements, these uncontrollable jerky muscle movements. That uses up quite a lot of energy and will burn off quite a lot of calories. And so you often find that you get quite a lot of weight loss from that, especially if the person isn't eating enough. So you have the stumbling, that lack of coordination. So they have clumsiness, which causes difficulty with eating and drinking, as you imagine. They become quite messy. They're quite frightened of spilling food. They may be embarrassed, so they then may avoid eating, particularly right in public. The memory is affected, the concentration, so difficulty in planning what they want to eat and when they want to eat it. And sometimes they miss meals because they completely forget and they don't always recognise that feeling of hunger like we do. Mood obviously will have an impact, so a loss of desire to eat if they're feeling depressed. And changes in appetite, obviously that can occur for a variety of reasons, including the swallowing problems. They might be frightened of choking, but obviously that might actually affect their appetite and they might stop eating. Okay. So what to look out for? So as Huntington's progresses, the muscles, as we said, become weaker and lead to a difficulty in swallowing. And that can occur at any point in the swallowing process. So it can occur at the oral stage, and it can occur at the pharyngeal stage, or both. So obviously before the food gets into the mouth, they might have difficulty coordinating that hand-to-mouth movement, so they may drop things, they may feel like they're going to cram food into the mouth, because they're trying to get food to the mouth as quick as they can do. And again, those involuntary upper body movements will make them drop things as well. And impulsivity sometimes makes them cram food into the mouth, and obviously that increases the risk of choking. Once the food is in the mouth, they may not always be aware of the food when it arrives at the mouth, and so sometimes they'll fail to do anything with it, so it can pocket in the side of the mouth and the cheek. And again, it's that uncoordinated and complete lip closure, so they may overfill, like we said, things may leak out. And they have difficulty chewing sometimes and moving that food to the back of the mouth, which we need to do to start off that instant pharyngeal stage. And what you might see is some excessive tongue movements, and food and drink can sometimes go quite quickly back or too slowly. So then sometimes the swallow isn't prepared. If it goes down too quickly, it's down and gone before they've had time to actually prepare the swallow. And obviously the swallow itself, we obviously, important things we always look out for is the term that we call aspiration. So that's when something enters the airway that shouldn't be there, it goes down the wrong way, and that's the pharyngeal stage. And sometimes you see quite a fast and uncontrolled swallow in people with Huntington's, and they struggle, again, like we said earlier, that breath control. So you get an incoordination between inhalation and exhalation. So they might take sudden gulps of air when they're swallowing, which means that they can inhale when they're swallowing. So again, that makes that aspiration risk a bit higher. So they may inhale as something is going down their throat, and they're at risk of aspiration. And sometimes you see regurgitation as well. So sometimes that can come back, like we said, food and drink can sometimes come down the nose, and sometimes that's if that soft palate isn't working to cover that nasal passage. Okay, so how can we recognise that someone is having difficulty swallowing? Refusing, maybe one of the first signs that you see they want to eat, and that can be obviously for a variety of reasons, like we said earlier. Your obvious signs are you're coughing, you're choking, but it's just being aware that sometimes people don't always cough. Sometimes we have something called silent aspiration, so obviously things are going down the wrong way, but outwardly the person is showing absolutely no signs whatsoever. It's important to be aware of other things as well, and build up that picture. So, like we just said, refusing to eat food, or refusing to eat certain foods. It may be certain foods that they're struggling with getting down. So crumbly foods tend to be an issue, flaky foods, chewy foods, those kinds of things. You might get some unexplained weight loss because they're not eating enough. You might see facial grimacing as well, because it might be difficult to swallow or difficult to move the food around, sometimes making their eyes water, it's stuck in the throat but not necessarily coughing. They might complain that food is not going down the right way, or it's getting stuck, they're feeling like it's in their throat. You might see excess saliva, so you might get some dribbling, or sometimes that saliva can go back to the throat and make people cough. and some mucus as well. You can get build up some mucus in the throat, and that was presented with like a wet or gurgly sounding voice. And sometimes when somebody had something to eat or drink, listening to that gurgly voice sometimes means that things hanging around there is not always gone down. Obviously, like we said, the gagging, the choking, the coughing, and changes in colour, changes in pallor. So they could be red in the face, they could be a grey, even a sort of a whiter colour if they're struggling. And you'll see sometimes the breathing rate after they've had a swallow will increase, so they'll come a little bit short of breath, and that's sometimes indicating that something's gone into the airway that shouldn't be there and they can't get rid of it. And one of the most important things that we look for is a raised temperature, because obviously that can be a sign of chest infections, and we're always looking out and we're always asking people how's the chest been, just to make sure that not having those infections caused by food or drinks going down the wrong way. It's important to say that obviously poor management of the swallowing problems can lead to aspiration pneumonia. So if you have enough material going down into the lungs, it then causes pneumonia. Obviously that can cause hospital admissions, and in some cases that, you know, people do die of aspiration pneumonia. It's very serious. Okay, so before we can discuss what we can actually do with swallow itself, one of the important things to always consider is mouth care. A build-up of bacteria in the mouth can be aspirated and result in aspiration pneumonia, and that can occur in patients who are ill by mouth. They're not having anything to eat or drink orally. They might have alternative means of feeding, but it's really important to make sure that the mouth is well looked after. If they've got dentures, making sure that they're regularly cleaned without that build-up of bacteria. And just looking for things like a dry mouth. Medication can make somebody's mouth quite dry. And again, if they're not having many fluids because of the issues, that will cause a dry mouth. And it's just important to encourage them to sip small amounts as often as they can. Okay, so what's our role in the swallowing? So obviously we provide an in-depth assessment of a patient's swallow. We'll often come along and assess them with food and fluid at the home or wherever it is they are, just to actually look for those signs and see how they're managing. Sometimes we'll do some instrumental assessments. Sometimes we do perform what's called a video fluoroscopy, which is an X-ray of a swallow. So we film them eating and drinking various consistencies of food and drink, and you can actually see whether it's going the wrong way, whether it's collecting, and that gives us good guidelines onto what to recommend in terms of diet and fluid changes. Sometimes they're not always easy to do because of the movement, so it's very difficult to actually do a video, but we'll do that if we're unsure of what's actually happening with the swallow. Obviously, we modify people's diet and fluids as needed. We'll liaise with the dietitians and the nutrition teams, and we're often involved in those decisions about long-term feeding or risk feeding, so whether a feeding tube is appropriate, whether that's in their best interest. And we'll look at capacity assessments. If somebody is having cognitive assessments and we feel like they're not sure about making those decisions, we can get involved with that also. Okay, so how can we help? So here are some of the advice and strategies we will give. So self-feeding can often be the easiest and safest for the patient. So before jumping straight, oh, they can't be struggling to feed themselves, rather than jumping straight to self, be to feed them, just looking at could verbal prompts work rather than actually feeding the patient. There may be times when definitely feeding the patient will help, but just having a little think about that as well. Obviously, if you are feeding the person, like with communication, a quiet, distraction-free environment is best when eating and drinking. Sit upright, obviously. You should be at eye level with the patient, don't stand to the side or above them. Sit in front so that you can be seen and the food can be seen, so they know when that food is coming to them. Never feed a patient lying down, and never encourage them to tilt their head back. You're at increased risk of aspiration if you're lying down or your head is tilted back. You think about in resus training when you have to blow air into a patient, they always tell you to tip their head back, and that just means that their airway is wide open. So if they're in this position when they're swallowing, the chances of the food or the liquid going down the wrong way are greater. So again, if you were stood above them and they're having to look up to get that food, the chances are that they're going to go down the wrong way. Making sure, obviously, that the dentures fit, if they're loose, obviously that can make the chewing or swallowing more difficult. And sometimes it can be easy to remove them or use a fixative if they've got dentures. Don't engage the person in conversation or ask questions when they're eating and drinking. Like we said about the coordination with the breathing, if they go to answer something, they may take a breath, they can inhale the food, and then it can go down the wrong way. If you are feeding, feed as slow as you can do. Make sure you watch for the swallow here before giving the next mouthful, and check that the mouth is empty before giving more, and it's not pocketed at the side like we said earlier. And just obviously referring to any guidelines that the speech and language therapists are suggested regarding any utensils to use or the diet and consistency. So sometimes we will use equipment. Like we said earlier, sometimes people tend to rush. They rush the drink. They, they're pouring it in, or they will put too much in and sort of shovel it into the mouth. So one of the things sometimes we use is what we call the Provala cup, which is just basically a cup with a little spout, and basically you sip it, but it only delivers a certain amount at any one time, so that you can't overfill the mouth. Obviously, we will do texture modification, even something as simple as a smaller spoon when they're eating, so a teaspoon rather than a big spoon, a smaller fork, whatever it is you're using, just to stop them putting too much on and putting too much in at any one time. But it's important to say that obviously if that person is in denial about some of the difficulties, then it is quite difficult to manage. So just being aware of that also. Okay. So as speech and language therapists, we now follow the ITSY guidelines. That's new guidance that came in recently, and it's changed the descriptions that we use. I won't go through this in great detail. There is a website. If you look up ITSY, if you Google ITSY, their main website comes up. And there's a lot of guidance on that website as to what each of the levels mean, the types of foods that can be offered at each level, and obviously your speech and language therapist should be able to advise you on those levels as well. Okay, so obviously one of the management strategies that we use is the use of thickener. Particularly the patient obviously has problems with their liquids. And the reason why we use thickener is it's used to slow down the drink as it moves through your mouth and throat, and that enables the person to control it a bit more and coordinate those muscles ready for the swallow. Sometimes we often use specific techniques to aid the swallow, but again, that'll depend on the cognitive skills, whether they can take those on board and remember what it is they need to do with the swallow, especially each time. Swallowing is an automatic thing. We do it, excuse me, we do it without thinking. We don't have to sort of always sit and think, right, I'm going to do this now. So remembering different strategies when you've done it the same all your life is quite tricky for people. Okay, making thickener more appealing if possible. Where possible, use cold drinks. That tends to be a bit more palatable than in the hot drinks. Offering the patient a cordial or a juice drink is again a bit nicer than in plain water. And just making sure you offer fresh drinks as frequently as you can. Thickener can reduce the hydration level of drinks, so making sure you offer drinks frequently so they're getting that same level of hydration. And as daft as it sounds, being positive. If you tell them, oh, here's your horrible thickener, or here's your, you're pulling faces when you're giving a drink, then how would you expect them to drink it? You wouldn't have something that was presented in that way. Okay, so just to end on, just a point to remember that deterioration in these people is gradual, and it's just being vigilant at all times, looking out for any changes. If you're a carer or a family member, you will know that person best and be able to give that information to the speech and language therapist. And again, we can't eliminate all risks associated with eating and drinking. We're all at risk. We all have chances of things going down the wrong way. But again, by following some of the strategies, the recommendations, we can try and minimise those risks as much as we can. So thanks for listening, anybody. And if anybody's got any questions, then give me some nice easy ones. That'd be great.